Howdy. All right. Our visitor this week comes to us from Harvard Medical School, where she is a translational physician and scientist in neonatal and perinatal medicine. She received her Bachelor's of Arts in Biology from Washington University in St. Louis and her medical degree from Cornell University Medical College in New York. After completing both her internship and residency at Children's Memorial Hospital through Northwestern University Medical School, our speaker spent 4 years as a clinical fellow at Children's Hospital in Boston before becoming an instructor of pediatrics at Harvard Medical School. In addition to her medical degree, our speaker also received her master's degree in epidemiology from Harvard School of Public Health.
Currently, our speaker is an assistant professor of pediatrics at Harvard Medical School and as well as the associate director of NICU at Beth Deaconess Medical Center in Boston, where she also serves as a chair of the NICU Nutrition Committee. Today, she will present fatty acid imbalance in premature infants, implication for altered development and disease pathogenesis. Please help me welcome Dr. Camilia Martin.
Good. Thank you. It's very nice to be here. And yes, I'm a neonatologist, so I take care of premature infants born anywhere from 23 weeks of gestation to term, and our field is advancing rapidly, and always interested in nutrition and growth, mainly because that's something that we directly deliver at the bedside. With our pen, we decide what that baby takes in. And with my epidemiology degree, kept describing the same issue over and over again. By the way, I'm recovering from a cold, so if I cough and interrupt, I apologize in advance. Kept describing that despite our nutritional policies and what we think the baby needs, premature babies don't grow very well after being born early. And it's something we call actually extrauterine growth restriction. And why that's important is how well they grow, how fast they grow actually dictates to some degree and linked to how sick they are in the NICU and even after going home. So as a toddler in kindergarten, how well do they do from their motor activities and their cognitive activities? So nutrition plays a very important role, not only in the NICU, but even after our babies go home. But I'm trying to get my own colleagues to think of nutrition beyond just providing calories and getting a baby to gain weight. That what we're doing is actually, if we understood better that intrauterine delivery of nutrients and fetal development and what we have to provide after, perhaps we can give them that nutritional armor such that when they have to get oxygen or if they have to be placed on a ventilator or if they get an infection, that what we have done nutritionally poises them to be able to attack that and be resilient to the damage that those effects may occur. But I think we have a long way to go, but I want to share with you sort of what I have learned in the process and where I hope we're going as neonatologists. So as part of my research, I do have research funding from multiple sources. I think in this competitive environment for research funding, it's important to do so. But many of my relationships with industry are with those companies that directly provide nutrition to babies. And I'm a bug in their ear telling them what I think is important and where we need to move for that next generation product to best give to our infants. And they're listed there. So I'm going to concentrate on lipid delivery, why we need lipids or fats for our premature babies. What are those requirements? What can we learn from those requirements and what we see postnatally to help define exactly where we need to go in that delivery, especially with fatty acids? And then identify and think with you and explain with you those challenges we have in bringing those theoretical desired new requirements and recommendations to the bedside. So a term delivery is considered 40 weeks of gestation. At 37 weeks, you're considered term. So anything less than that is considered preterm. We do take care of babies as early as 23 weeks of gestation. That's about 450 grams at birth. 454 grams is a pound. So they can be very small, and they're completely dependent as a result of us in providing those nutritional delivery back to them, because they miss almost all the third and some of that second trimester of all the deliveries you can think about. When you think about maternal transfer of immunoglobulins, proteins, fats, and those fatty acids, especially fatty acids that have this biomagnification in the third trimester for eye and brain development, they don't get it at all. So we have to think about, well, what do they need after they're born early? And so they miss much or all of this critical period. After babies are born and premature babies are born, we don't immediately use their intestinal tract. I'm not so sure that's the right thing to do, but we're at the bedside a bit concerned about, well, if we introduce food too early into the intestinal tract, are we going to cause more problems? Because these babies are not expected to see food or even digest food for another 3 months. But I do think it is important to show those babies a little substrate, but I'm going to concentrate on the fact that we don't feed them very well, and what we rely on is intravenous nutrition. So we put lines in their umbilical vein and their artery, and we deliver through the IV a certain amount of glucose and dextrose, a certain amount of proteins, and a certain amount of lipids. We have a general idea of how many calories to deliver and how much total energy to deliver so that they show this progressive growth. But this dependence on this IV can last for a while, mainly again because we're very slow and purposeful in introducing any feeds through the GI tract. So what this is just a graph. This is postnatal day in weekly intervals, 7, 14, 21, and 28. And this is the percent that are still receiving some parental nutrition. And you see at that first week of life, almost everybody is all dependent on getting most of their nutrition through their IV. But slowly, as we introduce more and more into their gut, they transition off their IV and then they receive almost everything by their gut, which is good. But that transition, the median day for that transition is 14 to 17 days. So when we're doing nutrition work in neonatology, we have to think about both the parental nutrition, the IV nutrition, but also that transition to gut nutrition. So I think of those as 2 phases of nutritional delivery that you'll hear more about. So with the lipids, so in general, and I know much of you know this already, class of organic compounds that are not water soluble, but again, they're bioactive. It's not just about calories and growth. They're of course important nutritionally, but biologically, they have so many different roles that are important for the developing fetus. The structural components of cell membrane, regulating cell signaling that regulates inflammation, but also organogenesis and even immune ontogeny. So all of these developmental factors that our babies should have gone through if they had remained in utero. But with that early delivery, they're relying on us to help augment or support these developmental pathways. And I think we have to think better about how to do that nutritionally. Here are some examples of lipids in our bodies, and fatty acids are much of the major building blocks in many of these compounds. So fatty acids being the long hydrocarbon chains that are capped by a carboxyl group. So saturated means every carbon is linked to a maximum number of hydrogens, and unsaturated where this is not so and they have some double bonds. And this configuration and how they sit in the membranes is very important in the composition of what types of fatty acids they receive, how bioactive these fatty acids are, and how they influence cell membrane and cell function. So much of our nomenclature that you'll see frequently in the literature is with this nomenclature, where the first number, 18, is the total number of carbons. The second number is the total number of double bonds, 1, 2, 3. And the number of carbons from the terminal methyl end is this number, N3, 1, 2, 3. There's the first double carbon. So that's how to read the fatty acid nomenclature. So in general, our practices are that we know they have very limited endogenous lipid stores. Our babies, I don't know has anyone had experience in seeing premature infants or being in a NICU or, yeah. So they're pretty tiny, and when they're born, they have absolutely no fat stores. They don't have any inherent adipose tissue or fat. And that is a reason, which I'll show you, that they go through rapid deficits of many of these nutritional compounds that they were trying to accrue from mother. So we understand that. And then we have to provide, again, the parental nutrition. We do provide lipids early, usually by the first day of life through their IV on a lipid emulsion called intralipid. And we're going to talk more about that. And it's necessary, even in small amounts, to prevent essential fatty acid deficiency. So providing those precursors of those fatty acids that are metabolized down to the longer chain fatty acids. It's also an important source of gluconeogenesis. If we didn't provide lipids and relied solely on carbohydrates or dextrose delivery, our babies wouldn't be able to handle that. They would become very hyperglycemic and reliant even on insulin therapy. And it's a very high energy, caloric dense food, which is great. We use stepwise advancements to get from 1 gram per kilo today to 3 grams per kilo per day, usually by day 3. We monitor tolerance by looking at triglyceride levels. And because of the tolerance and hypertriglyceridemia, we have learned that a 20% versus a 10% solution is usually better tolerated. So that would be the end of the lecture if we were happy with that, right? That these are our requirements and this is what we do. Great, we can all go home. But what I have learned over time is that we can continue to learn from our practices. And although this is what we have and this is still what we do, there's a long way to meeting what their fatty acid requirements are. And I think our current practices and not realizing or changing it actually may profoundly affect their overall health. And hopefully I can share what I've learned and we can get there someday. So we're scared of the intralipid, we're scared of the fats. Even though we understand cognitively that it's essential to provide a balanced diet, it prevents essential fatty acid deficiency, it's a high energy source, and it's a driver of gluconeogenesis. We also know that our preterm infants sometimes can't tolerate it with elevated triglyceride levels well into the 300s. That it may cause a pulmonary vascular resistance increase, so the pressures in their lung fields increase with lipid delivery. And that's been shown. And it may impact immunoreactivity, meaning is it toxic to the immune cells, making them more susceptible to infections? These are all theoretical, some soft clinical evidence that we can discuss at any time, and some animal evidence, but I don't think right now that those should outweigh the benefits of overall receiving lipids. And in fact, these common reasons that you may hear about why we don't give lipids in preterm babies, we do not hold for that. We don't think free fatty acids are going to displace bilirubin from albumin enough to cause a serious hyperbilirubinemia. We don't think that what we see causes lung disease because we know our babies get eventually better even with prolonged intralipid. Sepsis is a big cause to hold intralipids. In our unit, just using general infection control practices, we have not had a central line-based infection for over 2 years, despite using intralipid. So these may be more theoretical than true concerns. And the only one time that we do, in collaboration with our children's hospital, hold the total intralipid delivery, if we know they're going to be on it for a very long time, they can't transition to feedings with the gut because they have a surgical or a congenital surgical condition, like duodenal atresia or some other obstruction, then we'll bring it down a little bit because we do know prolonged exposure to lipids may cause liver injury. But other than that, try to convince our colleagues to continue to give the lipids, but absolutely we can do better than what we're doing now. But intralipid is currently our only option of lipid emulsion in this country, in North America. And I'll go through some of the different lipid emulsions that are available in other countries. But right now we're solely dependent on this intralipid. So when I started to get into this, and I thought, well, why are we so scared of lipids, and how did we get to the intralipid composition that we have, to just better understand how we got to this place. So I dug up my history notes and looked online and said, how did we first begin? Well, back in 1628, William Harvey discovered the circulation, and that formed the basis of all these studies where everybody was just taking animals and infusing anything in the veins to just see what their reaction would be. We would never get eye approval today. And in 1679, William Corten actually took a dog and infused direct olive oil into the vein. He actually presented this in 1712, and this is the monograph from that 1712 or 1678 study, but finally published in 1712. And you read it, and it's actually kind of funny, and at some point you read the whole thing, but describes in pretty good detail the difficulty in finding these small veins to inject an ounce of warm oil of olives, which they did with great deal of difficulty and very slowly. And then the rest of the paragraphs just describe hour by hour, minute by minute, the poor suffering of this dog. And then at the end here, thus in 3 hours after the injection, spent in sleeping and barking, he died. and have it open his body after he was dead, we found the bronchi of lungs filled with a thick froth. And I'll tell you, if you ask our neonatologists, they think that's what we're doing to our babies. That's how concerned. I'm like, this is where the fear of intralipids. And in fact, when you go down the timeline, very quickly, we were able to develop commercially available glucose and amino acid solutions that are well tolerated through the vein, but the lipids slowly followed. Many studies just about testing all these different things and these serious side effects that the USA put a total ban on any kind of lipid emulsion. Around that time, finally, Arvid Retland, here, if I'm pronouncing that Swedish correct, figured out a way, and what he realized is you have to emulsify, right? We now know oil and water don't mix. You have to emulsify the solution. And he used egg phospholipids to emulsify it so that he can infuse it and have it well tolerated. And despite doing that and having overseas approval, we delayed a little bit, and finally in 1972, we approved it. So intralipid is a soybean oil that provides your precursors, and I'll show you the fatty acid metabolism in a minute, provides those early precursors, kind of under the assumption that our body will then take those and downstream metabolize them to the longer chain of polyunsaturated fatty acids. But think for a moment, and then when I tell you the effects, what we do know in a neonate, we're using a product still in our babies that was developed in 1972 when neonatology was probably just beginning at most, and was designed for adults. So it is kind of amazing that we have this high technology, this NICU that we can keep anybody alive almost, but yet we're providing a very rudimentary early nutritional product in this intralipid. Now, since then, there's been many other studies on structured lipids, looking at MCT to our medium chain to long chain ratios, the addition of these long-chain fatty acids specifically as in the form of fish oil, and overseas they're a little more advanced than we are. I did have on this slide at one point, no new lipid emulsion was approved by the FDA, but I think just this past summer, Clinolipid was approved, but kind of disappointingly, it's another soybean olive oil, again, providing just in different ratios that early precursors. So we are currently using a product from 1972 that's all soybean oil. And here, this is what this means. A soybean oil, 55% is linoleic, 8% is your linolenic, and these are the descriptions of these different oils. So intralipid, 100% soybean, SMOF lipid, a soybean, medium chain, olive oil, and fish. That's how you get SMOF. A little more equally distributed. I'm going to show you some data on that use. And omega-vin, which is 100% fish oil, so giving very high concentrations of DHA and EPA. And I'll show you some of the data. But here's the fatty acid pathways. And again, when you're providing, the goal really was to provide those early, what we considered essential fatty acids that must be provided exogenously because our own body can't endogenously make them, and allow us to sort of our own body take it the rest of the way downstream, so that you do have DHA and EPA and arachidonic acid. But there's a lot we don't know in a developing preterm infant. Like, what is the activity of these enzymes that are necessary to take it from one step to the next? What is the utilization rate? How do we know how much to give? Are the requirements different from a baby than from an adult? What about a very sick, critically ill baby on vasopressors to maintain blood pressure, on ventilators? Is their metabolic need and requirements even higher? And a lot of those questions are still unmet. So I do think with the new generation and learning more about what lipids do and what they do for our preterm babies in a developmental way for optimal development, not just nutrition, we can get closer to a next generation of lipids that specifically treats the needs of the preterm babies. So what does happen in a normal situation? Well, during the third trimester, I had alluded to that they call this biomagnification of fatty acids from mom to baby. There's specific receptors and mechanisms within the placenta that to primarily transfer and give to the fetus DHA and AA. If you label all the other fatty acids in the maternal circulation, you see no change or no significant transfer. So teleologically, we know already that Mother Nature has put in systems to make sure that the fetus is getting substantial amounts of DHA and arachidonic acid. And one lesson I would love for, if you take one thing home, is that it's not just about one fatty acid. We hear a lot about DHA in science, but also in the lay public. It's not just about one fatty acid. Our bodies are not that simple. They all act in concert with one another, and it's also important to have a balance of different fatty acids, and arachidonic acid is just as important, if not others. So there are specific mechanisms that transfer this to the baby. And even though there's a high concentration per weight of tissue for the brain versus the adipose tissue during those last few weeks that our babies miss, where babies essentially just get fatter in utero, they're building these stores so that after delivery, they have a reservoir to draw from during those first few months and that first part of the first year of life to continue to develop their eyes and their brain. So our preterm babies don't get that luxury of creating that adipose reservoir. And so what happens is they go from this very high DHA to AA environment, and then they're born, and we don't replace any DHA in AA. We start umbilical lines, and we infuse intralipid. And I just told you what intralipid was, 100% soybean oil. So we don't use the gut. We're too scared. And then when we start to give it, we give it very slowly. So they go from a rich environment to almost nothing. So when I started to ask and move from this primarily training of epidemiology to translational research, one thing that's nice is that when you're kind of formulating your ideas, talk to everybody and anybody, because it's amazing that there's a lot of shared mechanisms out there across populations and across diseases that you can learn from. And I was speaking to one of our adult gastroenterologists in our hospital who does fatty acid metabolism and cystic fibrosis. And I tell him, I say, our babies are immune and competent. They get lung disease. They get bowel disease. They're susceptible to infection. He says, it sounds like there's cystic fibrosis, but they're not. But he's like, maybe, he had been doing a lot of fatty acid work in cystic fibrosis and showed that it was have abnormalities in those profiles. So what do we know what happens in the preterm infant? I had no idea. So I set out and decided to collect a series of samples, started what we call an infant biorepository. We're longitudinally over time, collected everything that came out of that baby, urine and stool, and then all the breast milk going in and discarded blood. And one of the first questions after we got to 100 infants enrolled in the biorepository was to ask, what's the natural history of these fatty acid profiles after they're born, and may reflect some of our practices. And so along the x-axis here, you see the postnatal week. So we have birth levels, 1 week, 2 weeks, 3 weeks, and 4 weeks. And along the y-axis, the mole percent. This is whole blood fatty acid profiles done by GC mass spec. I didn't know where they should be. So we did do 10 term infants just to see at birth where they should have been if they had remained in utero. So you see at birth, they're about 7.5 mole percent, but on day 0, they're also about 7.5 mole percent. So also something I was learning along the way is when the person I was working with, who I just mentioned, when he saw that, he was like, he couldn't believe it. He said, what we have in our bodies, if we were to measure ourselves right now, are probably 0.5 to 1 mole percent. If you take fish oil pretty regularly, maybe you can push it to about 3 mole percent, but that's it. So another signal, I think, the fact that these babies are born sitting at 7.5 mole percent tells you it's important. And so they're doing pretty well, and surprisingly pretty well at birth, but immediately by the first week of life, we almost half the DHA level, and it plateaus even out to 4 weeks. I didn't check any longer. I'll tell you, it's probably not changing. And I looked at whether you got breast milk or formula and all these other things, whether it differed where you were sitting out here after that first week of life, and it doesn't matter. And it doesn't matter because we allowed this deficit to accrue pretty rapidly. And so we looked at the other two kind of major ones. Linoleic acid triples from where it started. Again, similar to terms, but within a week, triples. But that's what we're pouring in their IVs. So not surprising retrospectively that their linoleic acids are so high. And then arachidonic acid, also almost to the levels, a little bit more so than the term infants, and then showing a similar pattern to the DHA. So I find it pretty remarkable that within a week, we flip the entire fatty acid profile and the balance to one another just based on our own practices. And that can't be good. I mean, just think of any sort of biological marker in you, and then within a week, we're going to turn it upside down. There must be some consequences, or maybe or failed consequences by not having fatty acid profiles where they should be sitting. Not that it's a magic bullet or it's the only thing, but I think it's an important factor in nutrition. And again, we're pouring it in, so that's why it's tripled. So what about the enteral practices? And there's other folks, there's a lot of other folks also looking at fatty acids in neonatology. And what I like about this person is he also put in what you're getting through your enteral diet. So he said, okay, let's take both. Maybe together we're making up this difference. And no, and, even though we steadily increase week by week, the total DHA we're delivering, you just go, the longer you go not meeting those early needs, you just continue to acquire a worsening deficit in this long-chain fatty acid. It's estimated that to maintain what that in utero accretion rate of this fatty acid, you need to deliver about 45 mg per kilo per day, and we don't get near that with any of our practices. So this is a failure on our end, and I think we're beginning to understand, but it's a failure on our end to understand what that nutrient requirement is after early delivery, what we need to do to replicate what should have been going on if the baby had remained in utero. So what can we change to address these concerns? And the more I do fatty acids, I love what they do. There's so many different functions, and it just keeps instilling why it's important to solve this problem. So it's important in the fatty acid tails of the phospholipids in the cell membrane, and the fluidity and function allow for signaling to the nucleus. And at first I actually had just immune and inflammatory responses because I knew those were kind of tried and tested. But the more I do work, I'm realizing, especially in premature infants, which is a developmental model, it's almost like developmental biology, there's other functions as well, such as organogenesis, which I find exciting, that there is a possibility that if we learn how to replace something in an effective manner, we're not only regulating inflammation and immunity, which is long written, even into the adult literature, but we may be also playing a part in how these organs continue to develop after delivery. And there's accruing evidence in each of these diseases of prematurity that fatty acids are important. This is lung disease, bronchopulmonary dysplasia. We have to breathe for our premature infants. We give them surfactant, but you're in between a hard place and a rock and a hard place, where you have to give them oxygen, which is toxic, can be toxic to the tissues. Life-saving and toxic, everything, right? A neonatologist. Ventilator, life-saving but causes lung injury. So we always have to balance these competing risks. Sepsis, neurodevelopment and brain development, intestinal injury and necrotizing enterocolitis, which is our version of inflammatory bowel disease, and retinopathy of prematurity, which is actually thought to be partly inflammatory driven, but an altered angiogenesis. And that's what accounts for the retinal detachment that occurs sometimes in premature infants, thankfully fairly rare now, but it used to go on to significant rates of blindness. There are studies outside of our lab that have looked at each of these and the role of fatty acids in determining these pleiotropic effects. So again, something that's worth getting right if we can prevent some of this. So going back to the repository study, I'm going to give you just a snapshot of each of these different diseases and how fatty acids have been looked at. So in the repository, we saw the changes in fatty acids, but the always next question is, so what? I mean, premature babies have to go through metabolic changes. Maybe that's actually an appropriate one. So we looked again across the x-axis where your DHA level was across the longitudinal time, and plotted out, okay, what was your curve if you did not get chronic lung disease, and what did your curve look like if you did? The green is with the population as a whole. And you can see that those that were at risk for chronic lung disease had lower DHA levels than the kids that did not go on to lung disease, such that every mole percent drop in DHA, they increased their risk of chronic lung disease by 2.5-fold. And do notice, though, that some kids did okay, and but still had that early pattern of decline in that first week. This is a secondary data analysis that lends to that, or kind of builds into that argument that DHA may be important for chronic lung disease. This was a study. So other groups have tried to figure out how can we best get DHA to our babies now. So this group actually supplemented moms and showed that moms supplemented had higher levels of these fatty acids in breast milk and then fed the babies. I'll talk about that strategy again in a minute. And their primary outcomes of improved neurodevelopment didn't pan out, and I have some theories on that. But then they went back and did a secondary data analysis to look at chronic lung disease. And you can see in this sort of post-hoc analysis in the smaller kids, less than 1,250 grams, and in male infants, they had a decrease in the number of infants that went on to have chronic lung disease or a dependency of oxygen despite being almost term now. So some evidence there. So our group was trying to figure out, well, how can we start to show some causality to it? Because you could always argue that clinical data and all of these are associations and not much more than that. And so we said, well, if we can't fix that early deficit of providing DHA and AA, maybe if we just from the get-go provide what we think are the important mechanistic molecules from these fatty acids that impart its biological benefit. So for example, DHA goes through a process where one of its metabolites is resolved in D1, a terminator of inflammation. It is thought that our babies just don't know how to stop inflammation. They're not just high in inflammation, they have an absence of negative regulators. And then arachidonic acid goes on and does lipoxin A4. So we attempted on this hyperoxia lung injury model in neonatal mouse pups. So what this was is that we took neonatal mouse pups as soon as they were born, separated them from, well, we randomized. They continue to be damn fat. We randomized either they were stayed in room air or they were placed in 90 to 95% oxygen. And what you see in this hyperoxia model, this is a normal lung. Nice small lung units, the walls between the lung units nice and small, and a lot of them. But then when you give hyperoxia, and this is no change in magnification, you get these really thickened walls between your lung units, and you can see that those alveoli are widened, and they're big. They're not nice and small and numerous, and that's called alveolar simplification or arrest in alveologenesis, where they just stopped making those little lung buds and instead just have these large open spaces that are ineffective for oxygen delivery and these very thickened. If you were to take, it's a fairly accepted model of lung injury for neonates. If you were to take the autopsy of premature babies who died of BPD or chronic lung disease, it would look very similar to this. And so we had an arm that we treated with just the resolvin. And at first glance, I was like, oh man, didn't change it much, right? You see the lung units really just as big. But if you look closely, the walls are actually very thin again. You give lipoxin, you start to see some improvement in the number of alveoli. It's not quite back to normal, but they also maintain very small, thin walls between their different alveoli. And then you give them together, and there seemed to be maybe some synergistic effect, where despite being in 10 days and 95% oxygen, you look pretty darn close to what a normal lung is supposed to look like. And so when we did some real-time PCR to figure out what are the promoters of these changes. And what we found was that resolvin D1 sort of down-regulated, brought down your interleukin 1 primarily, and an extracellular matrix protein, so the proteins involved in these interstitial spaces of TIMP. And then lipoxin did that, but one of the things it did as well is it also upregulated TGF, a growth factor, and its SMAD signaling important in lung development. So this I was pretty shocked by. I didn't know quite what to expect. I was hoping for this anti-inflammatory effect, but didn't realize that there was going to be effect on lung development itself. For sepsis, going back to the repository data, we showed that arachidonic acid, every 1 mole% drop in arachidonic acid, you were at a 40% increase in getting a nosocomial infection. How about fatty acids in neurotissue development and brain development? So mentioned already that with that early transfer of fatty acids, very important in eyes and brain. But again, often we talk about DHA. And this is from Martinez studies, autopsy studies of human infants who died of non-neurological causes. many of them, unfortunately, sort of unexpected deaths. But what he was able to do was look at the fatty acid profiles in total brain as far in his retina. And, he had kids that were able to plot at different postnatal ages as well as different gestational ages. One thing I want to pay attention to is this is the DHA to AA ratio. So if you're less than 1, your denominator's higher, your arachidonic acid, more important in total brain. Some DHA is concentrated sort of like in your frontal cortex, but others, if you look at the total brain, arachidonic acid is pretty important almost throughout this whole postnatal period. This is a preterm infant with maintained on a very prolonged high N6 to N3 intake. Here is another preterm infant on IV nutrition, and here's a term infant. So you can see that these, he just had a few kids, but these preterm infants maintained on current, the nutritional practices are well below what would have been a normal developmental composition of the brain in these fatty acids. Now, a term infant didn't look so bad. And I think that goes back to that adipose reserve, the reservoirs where you may have a depot of these fatty acids to help maintain you during these postnatal periods where your nutrition may be a bit suboptimal. In the retina, you actually see that arachidonic acid, this is across gestational age, is quite important, but at about mid-30 weeks, 32, 33 weeks, DHA now becomes the predominant fatty acid. Here's the one infant, that infant here. If you look and see what their retinal profile was in a preterm infant, way off sort of what that composition of that fatty acid should be in the retina. So we perturb pretty efficiently these fatty acid compositions. Still on the brain, but a quick point on the cell signaling. This is why, I had mentioned of going through unsaturated versus saturated is just, it really helps. And if you have all saturated, you're pretty stiff and with the signaling, but you incorporate DHA or other polyunsaturated fatty acids, you begin to be able to spread out a little bit, have a little bit more fluidity. And some studies have showed even improved signaling when you replace those fatty acid tails with polyunsaturated fatty acids. And DHA in the brain is thought to be protected by 2 mechanisms. One is through its direct metabolism to neuroprotectin D1, but also through the MAP kinase pathway, the production of BDNF. And so I just want to show you the importance there in that BDNF pathway quickly. And when you have BDNF present, you activate the AKT pathway that goes on to be important regulators of gene expression for proteins important in growth, survival, plasticity, and active organization and so forth. So there's been studies on BDNF, and like many markers that we look at after preterm delivery, you'll have a reduction in BDNF. And there's some nice rad studies from RAO, I think RAO, that does DHA deprivation and shows that when you deprive a DHA, you further decrease in your BDNF levels. And so if you think about the story I just told you and showed you the curves that I just showed you were the preterm infants, that's what we're basically doing. We're creating a scenario of DHA deprivation and therefore likely bringing down the BDNF. I don't know. Hopefully I'll be able to look that actually in preterm infants or preterm infant models. And once you give back these fatty acids in time, Rao showed in his rat model, you begin to correct the BDNF. And so this I just thought was a nice series of different studies coming together, basically telling us that we're depriving our babies of DHA, and they're in this chronic deprived state. It's not an acute change, but a chronic change. How about intestinal health, which is of specific interest for me? This is a schematic. It's actually from a journal looking at fatty acids in adult bowel disease. So in adults, I think the effect on fatty acids on intestinal health is a little bit more developed, but thought to be important in regulating the microbiome, being a negative regulator to TLR4, which is a receptor that many think that is overexpressed and may be the beginning of a cascade for the necrotizing enterocolitis, the intestinal disease I was telling you about. It's also important in that bilayer incorporation in producing those terminal mediators such as the resolvin, but also negatively regulating some inflammatory eicosanoids, and also may have a direct impact on NF-kappa beta signal transduction through the PPAR gamma. So many different mechanisms which a delivery of fatty acids into the gut may modulate intestinal health and inflammation. So there's only been one group, I think, that has really embarked on this consistently, and that's Mickey Kaplan's group. He's a neonatologist out at Northwestern, and he has a rat model of necrotizing enterocolitis, which is, the models for that disease, I think, are a little archaic. We're trying to get better at it, but basically what you do is you take a neonatal pup, you gavage feed them a formula. So you take them from mom, you gavage feed them, and then you put them under hypoxic conditions at least 2 to 3 times a day. Some have added hypothermia to that, getting them cold. I mean, if you were to outside, you're like, that's like, no wonder they don't feel bad and they get disease. I mean, that's a pretty brute force sort of animal model. But the only thing we have right now that induces an intestinal injury that may be similar to necrotizing enterocolitis. And so of that regimen, believe it or not, only 50% go on to get necrotizing enterocolitis. But when he replaced the feedings with DHA supplementation of egg phospholipids, or both DHA and AA, he saw some attenuation of that disease expression, and mainly through a decrease in platelet activating factor, as well as a decrease in the TLR4 gene expression. So, finally, the eye, retinopathy of prematurity. This is from a group, an ophthalmologist at Children's Hospital in Boston, right across the street from me, this is a mouse model, and they actually looked at this in several different ways. But basically the model was that the mice were reared with mom, but taken from mom a few times a day and exposed to hyperoxia, increased oxygen from P7 to P12. And then they isolated the retina, and they looked at the neovascularization. And so when you have this abundant neovascularization, all these are actually abnormal blood vessels that lift the retina, and that's what causes the injury and eventual blindness. So they did it in 3 ways. The first way was that they changed mom's diet. So mom was either an omega-6 dominant diet or an omega-3 dominant diet. They showed that the breast milk content was different in these fatty acids, let them continue to dam feed, and then after the exposure to oxygen, saw the difference. And they saw this difference where omega-3 dominant had a reduction in that abnormal angiogenesis that leads to retinopathy of prematurity. The second model they did, this is in Nature Medicine. The second model they did was a FAT1 model. So humans, we can't bounce from the N6 to the N3 chains. We kind of stay within that one chain. The FAT1 can actually jump from N6 to N3, to put it simplistically, and they showed the same thing, that in a FAT1 model, you get more of a protective effect against hyperoxia or the increased oxygen exposure. The final way they did it is sort of what we did with the lungs, is they said, okay, let's take Resolvin, and they also looked at neuroprotectin and give these to these mouse pups and expose them to oxygen, and they showed the same thing. So in several ways, they showed the benefit of an omega-3 dominant sort of exposure and the protection against eye disease and angiogenesis. So putting it all together, I think what's happening here, and again, not that fatty acids are the cure for everything and everything that we experience, but I think we just happen to be in this developmental model of prematurity where they are dependent and reliant on some of these mechanisms for appropriate development across the entire system. And so I showed you phase A, that during that early critical period, you get these fatty acid deficits and alterations. And we don't correct it. We let them sit there. And while they're sitting there and continuing to develop in the NICU instead of in utero, they're also having all these other insults and stimuli to their care that is beginning to impact organ development. And they have no nutrients, nothing else to fall on or draw from to help ameliorate from those insults and those stimuli for appropriate development. So it's the chronicity of this fatty acid imbalance. And then out in the long run, we see these morbidities. We see the lung disease. We see the altered immune system, the infections, and we see the impaired neurodevelopment. What always impresses me on the neurodevelopment studies is we'll take a cohort of babies, say if you were less than 23 to 28 weeks of gestation, and they say, oh, those that got NEC were at a 40%, 40% of them were so cognitively impaired, they're considered, mentally deficient, 2 standard deviations from the norm. But you look at the controls, always look at the control arms in the studies, and I think you learn a lot. You look at the controls, and that rate's almost 30%. So in absence of NEC or in absence of severe lung disease, in absence of growth restriction, we still have babies that are at high risk for these cognitive impairments. There must be something else. It's nice and easy to look at the impact of disease, but look at the impact of practices in nutrition, and maybe you'll help start bringing down that 30% of cognitive impairments that are our control groups. So how can we change this? Well, we need to improve lipid delivery, and one thing is we need to move away from just looking at fats, our total fat delivery, but actually look at the fatty acids that we're providing. So not to say, oh, we're giving 3 grams per kilo of fat, but what are we giving within that fat? What is that composition in that blend? Does it meet the needs of the baby? And then the other thing is maybe growth is not our final parameter. Maybe that shouldn't be our end of our outcome measures. Maybe it shouldn't even be neurodevelopmental impairment or a yes and no on these major disease classes. But rather, we may learn more if we start to look at the pathways to these disease processes and have immunity as our endpoint, or inflammation, or organ development. Maybe those should be our endpoint instead. Use sort of finer tools of assessment. I mean, I think looking at growth rate, like trying to do an appendectomy with a butter knife, I mean, it may be just too crude and coarse. I think we need more highly precision tools to really inform what our practices should be. So let's look quickly at the parental phase. So that's the phase I say where they're completely dependent on the IV, and it usually lasts around 2 weeks. But what are we going to do with IV nutrition? And other lipid emulsions may be available to us. And what have we learned? Well, I think what we've learned is that there's always something good about something and there's always something bad about it. And I think that's also whenever we think we've solved one problem, like we would give steroids for lung disease and almost get them off the ventilator within a couple of weeks. They wouldn't have chronic lung disease, and we thought it was great. We finally found a way to manage their lungs until somebody said, well, what happens later? And we found out when you did MRIs on the kids who got lung disease, their brains didn't grow, and they were at 3-4-fold increase of risk of cerebral palsy. So a lesson we learn in neonatology all the time is what's good for one system may not necessarily be good for another. And I think I'm falling and seeing that a little bit with the fatty acid information. And so it's a bit of a challenge to me and something I'm going through right now with some important colleagues about how do you weave and tease out what that message is trying to tell you. So this group used omegavin plus the quinolaic. So this is the soy and olive oil, but they added some fish oil. So they were giving more DHA and EPA, and they used a historical control. So they just went back to their books to look at, well, what we were using before, did it make it better? So just looking at outcomes, otherwise the groups were fairly well matched, they thought, well, maybe there was a hint better in getting the fish oil supplements where there was less cholestasis. The numbers aren't huge, though, but maybe a little less liver injury and maybe slightly less need for retinopathy of prematurity treatment. So it's intriguing, but I think before, again, maybe the answer isn't in the outcomes, it's actually in the intermediary pathways. So I was very appreciative of these authors for a couple of papers they've done now, where they've looked at a population still somewhat small, where they looked at mainly a they didn't say these names, but I think these are the lipids, lipofundin and lipoplus, where lipofundin is MCTs and soybean, and LipoPlus has the 10% fish oil in it as well. And so they were comparing these, and then they actually looked at blood levels and fatty acid levels, which arms you with a little bit more information. So if you go to panel B, which is your DHA, you see that neither actually prevents that large deficit early on. So one question continues to be is how important it is to eliminate that deficit altogether. We're clearly not delivering it fast enough or a high enough amount of levels to attenuate that. But the DHA group did, the fish oil group did end up with higher levels than the control. So you're beginning to move the needle a little bit. But if you look here on panel A, this is the arachidonic acid, the study group is here and the control group is here. So increase, everything is a plus and a minus. So increasing and driving up your DHA, you actually bring down your AA. And I think we have to be thoughtful about that because hopefully I convince you with the brain data and the autopsy data and other things is AA is just as important in a developmental model. So what are the benefits and risks of driving DHA to certain levels, knowing you may have to compromise on your AA levels? Or what are other strategies so you don't have to compromise? Maybe it's a theoretical risk that I shouldn't worry about, but it's all these additional information of how they play off each other that's important. Here's another one, is the EPA. This is substantial. So these are your control groups. Remember, with the fish oil, it's not a DHA purified, it's DHA plus EPA, and the EPA goes sky high. So EPA, we know, affects platelet function and bleeding time, and it's great when you're 80 and an atherosclerotic patient and male and preventing heart attacks. But is that something I want to do? Is that a biological parameter I want to force in a 24-week infant that's already coagulopathic, who's at risk of bleeding in the brain and in the lung? Maybe not. Maybe it's me just getting all excited again, or maybe it does have important ramifications that we have to figure out. Is that where we want our babies to be? So even the newer fish oil emulsions, I'm not quite sure, give us the complete answer. I do think it's probably, I don't know. I was gonna say I think it's probably better than Intralipid, but actually I don't know. I don't know if those trade-offs are actually better or worse. This is the author and the team that did that first study, and they followed up looking at other parameters, and finally it was like, people are starting to see that these are trade-offs, that you can't just go with pure fish oil. They talk about whether the benefits of increasing DHA outweigh the potential negative effects of the reduced arachidonic acid, and they also show that there may be some reduced lipid tolerance as well. And so all that mobilization and clearance of an IV given lipid droplet may not be as tolerated, maybe worse than the intralipid, where I told you they already had problems with their high triglycerides. So it's these kind of relationships that I think we have to be very thoughtful about before we figure out what to do. And so collaborator Doug Byrne and Baylor and Texas Children's Hospital is helping me sort of figure out some of these relationships. So in a premature piglet model, we've been able to infuse over 10 days different lipid emulsions, all the ones I just mentioned, plus a other couple of different ones. And through those samples, don't have a whole lot of data for you yet, but one, are we correcting these fatty acid profiles? What are the profiles based on these different fatty acid compositions? What is the tissue like? What is the incorporation into the tissue? Where is the active site of these fatty acids? Does it improve or make worse the inflammatory state of the preterm piglet, especially when you impose an insult? And in our case, we were doing an LPS sepsis model. What does it do to immune and inflammatory cell function? And does it begin to optimize organogenesis and ameliorate disease, or does it go the other way? So very systematically trying to go through these different fatty acid compositions using the preterm animal or piglet model to really look at these different questions. And how I'm starting to begin to think about it is sort of you're priming the host. So if you think of the preterm infant as the host, and I'm giving nutrition and I'm giving lipids. So I'm setting up a specific metabolic state, a nutritionally metabolic state for that infant. And then they get lung disease or an infection or something else. How ready are they to fight against that insult? And my theory is that it depends where we have primed them, where their immune state is, where their inflammatory state is. How ready are they? Are they not ready and they succumb to lung disease and infection and necrotizing enterocolitis? Or are they more appropriately developmentally balanced so that they can fend off some of that and not get infection and not die and not have intestinal injury? So it's the priming of the host. And so for a recent grant, we thought about that. Okay, if you have this first period where you abruptly stop, but this whole second period, we're priming them with our nutritional practices, how does this influence your risk of this? How does priming influence your risk in response to disease? Why do I have some infants the same gestational age that get lung disease and others don't? Why do I have some infants that look like they're doing great and get necrotizing enterocolitis and die within a day or two? But another baby, or its twin, that didn't happen. So what is it that's different about the host susceptibility? And for this specifically, how are we driving host susceptibility based on our nutritional practices? So just from a subsample, I wanted to get an idea about this priming. Like, do these babies or piglets start to look similar to each other depending on their nutrition? And so this is a component analysis, just looking at all those different factors that we ran with a company called Metabolon to look at all these metabolites. How similar were these two group patients together? So at birth, it was pretty nice. They actually all clustered really well together. But if you were receiving intralipid, the soybean oil, you were here. And then if you were receiving Omega-Vin, a little bit more scattered, you were here. So they're not in the same place. So there is some differential expression of that host based on the lipid they were receiving. I have no idea if being here is better than being here. And then you give LPS. You give something that simulates a sepsis-like syndrome, and you go from here to here, and then here to here. It's more spatter in the Omega-Vin group. The intralipids are more tight. Again, I don't know if it's better to be there or there, but what I do know is that it's very different. They're distinct from each other. So there may be something about the induction of the host response through fatty acid delivery. If you look more closely at some of the metabolites for linoleic or intralipid, you get this linoleic oxidative metabolite called 9,10-dihome that's only in the intralipid group and not the Omega-Vin group. So you look at the literature, and it's well described that this metabolite in adults basically paralyzes your immune cells. So that's probably not a great thing, I don't think. But then you come across data like this that we're trying to figure out what it all means. Like, is this good or bad, the polyamines? Well, it depends, I guess, on the context on learning and also the response. But polyamines in some population can be very important for development, but polyamines in other populations can actually be toxic. So how do you begin with all this big data know whether something that's overly expressed is a good overexpression or not so healthy overexpression? And that just shows that. So how about the antral phase? I guess I'm going to run through this. So the antral phase of delivery. So some of you may be saying, well, we've been putting DHA and AA in infant formula forever. We should know whether it's good or not. And if you look at the meta-analysis and the Cochrane systematic reviews, it doesn't seem to make a big difference in organ development. Now, I don't think that's a failure of DHA and formula. I think it's a failure for us to understand how we need to provide it. So this is all enterally fed, and this is just data to show that it wasn't as optimal as we were hoping. But the problem is that it's too late. So we're giving enteral feeds here. And I told you, we don't move the needle out here. This is where I think the money and the intervention needs to be. So all those enteral studies, all those formula studies, all the ones that show no signal to maybe a little one, I think it's the approach. It's not the fatty acid that may or may not be important. It's the approach. We don't know how to give it. Plus, if we give it enterally, as you all, I'm sure, have learned, the process of digesting a lipid droplet, breaking it off the backbone and the free fatty acids, entering into the epithelial cell, and then packaged back into your lacteals and delivered to your tissues, all of these places, there seems to be developmental regulation and a deficit in preterm infants. So if you're going to give a fat enterally, which is probably better than IV, you also have to think about how you're packaging that fat to overcome these developmental deficiencies in processing enteral fats. And so we looked at that quickly from that repository. I then took the stool in the breast milk. I was able to quantify from formula breast milk exactly what they got in and exactly what they were basically putting back out in the diaper. And you can see that as carbon lengths increase, especially with formula, breast milk is pretty tight and it's pretty nice. There's lipase in breast milk, not in formula. You look at formula, as your carbon lengths increase, you get a decrease fatty acid absorption rate. And then that's especially with the longer DH1. You see some biological variability, which I think is good, but you compare to a substrate that has those components in there needed for enteral digestion. There's a big difference. And that so people say, okay, then just give more. If they absorb 70%, let's give them 100%, 110%. But that accumulation of fat droplets may in fact impair and begin and initiate some of the intestinal injury. So giving more is not always better. Finally, so we've learned that gut maturity and that active gut response in a preterm infant, and when it's maladaptive, can cause intestinal injury, but the gut can also be the driver to systemic disease. But one of my pursuits is, well, how do we know what medications, what breast milk and nutritional practices influence that very first step? So Rob and Jason, I don't know if he's here, are helping me with that in their lab. They're able to look at intestinal cells that are shed from the intestinal tract and isolated from stool samples, and then look at the gene expression profiles of them. And going through this process and comparing to term infants, we see that in fact, yes, there is differential expression of specific genes when you compare to a term infant. So yes, a preterm infant is developing, and what's turned on is very different than a term infant. And sticking with the lipids is, I was intrigued to see that some of the genes and one of the pathways that were very different between the two groups was the lipid metabolism pathway. And one of my hypotheses, and then also immune cells, or immune function. So one of my hypotheses has been, in looking at lipids IV, but also Antral, is if we don't understand how the gut processes enterally delivered fats that already may have an altered lipid metabolism function in the gut, how does that interplay with immune function and then actually cellular health and homeostasis of the gut? And we're starting to see with this early data from Rob's lab is that there may be some intersections in these profiles that are unique to the preterm infant. So we need to define the target levels. We need to know that dietary balance of N3 to N6. We need to think about the positioning of these fatty acids in the delivery so that they're efficient in incorporating into the cellular membranes of phospholipids for their action. For enterally, we need to optimize those digestion and absorption. Is it structured lipids? Is it putting it in a package that's preformed into a micelle? Is it adding exogenous lipase? Is it putting it through something that's digested, pre-digested first before you deliver it? There's all these fun strategies that you can think about that may help a preterm infant. But ultimately, you want to achieve this adequate level of the tissue in the cell. So hopefully I've convinced you that LT-PUFAs are biomagnified during fetal development and thus are very important for neurodevelopment, and that they remain a critical component of our PN for many reasons, but we need to understand that what we're providing now is not optimal, and that there are new generations of lipids that we need to understand the function of fatty acids in to be able to detail sort of what that new generation product should look like. And that these changing profiles are implicated not only in disease pathogenesis, but overall health. And so looking at both parental and antral, so there's been a long history of fatty acid work in the antral world, and I think it's been great work, and we've learned a lot from them, but it's also about timing of delivering and what we're delivering. We got to consider the role and balance. We can't be just DHA-centric, and we have to prevent these early changes. By the time our infants see this, they've already, their disease pathogenesis is destined. They are, by 7 to 2 weeks, 7 days, 1 week to 2 weeks, they're already in that path and in that lane about whether or not they're going to get a specific disease. But hope that as we have future studies, and especially human studies, that these investigators not just define based on health outcome, but really look at the mechanisms so we can understand better. So a whole crew of people are involved in helping me sort all of this out. So the lab back at home, Doug Burns' lab, and the preterm piglet model, our biorepository team, the Van Dyke lab in Forsyth helping me look at those terminal metabolites and lung injury. These collaborators that I'm constantly talking about with the microbiome and neck. Rob helping me on postnatal intestinal development specifically, and of course the funding sources. So thank you very much for your attention.
We're running a little over time. I'll let one question, and then of course the students can ask many questions during the lunch.
Yes, join me for lunch.
One burning question that absolutely has to be asked. If not,